what it did do to us and the changes that have affected our lives since then, good and bad. And we're hoping to educate you through this so that we can move forward with a common purpose to bring more awareness and education and research and action into Canada so that this treatment would be available to anyone who seeks it. Tonight we are privileged to have with us Dr. Bill Code, who's going to be giving us a little bit of a medical introduction to the concept of CCSVI. For those of you that may not be aware of it, the ins and outs, the speakers, we feel like we've gone to school and had a quick indoctrination into our own anatomy and everything medical. So we'll be using a lot of the terms that Dr. Code will introduce to you, and they've been flipping by on the PowerPoint as we go tonight. So hopefully you've been doing your homework. Dr. Code is not only an anesthesiologist, but he was diagnosed in MS and became very much into the holistic practice in the management of MS. And it's a natural complement for him now to be speaking to us about CCSVI and its potential to open up new avenues of exploration for therapy for this illness. So thank you very much, and I welcome Dr. Code.
Thanks very much, Sandra. Can you hear me okay at the back? Works? Okay, good. Anyway, it's good to be back in Victoria. I came with my mom all the way over the Malahat because we live in Duncan. And it used to really surprise people that we'd come all the way over the Malahat just for a meeting, right? And then I'd say, well, and then we're going to go home after over the Malahat. But the Malahat's a lot better than it was 30 years ago. So it's a pleasure to be back in Victoria. I want to compliment Sandra for putting this evening together because there's much happening here and there across the country. And I think this is the first significant event of this kind. There was one in Calgary a couple of months ago, informational based, but you know, this is the first one on the West Coast that I'm aware of, and it's great to see you folks out. We're not going to, spend a lot of time with that. I wanted to outline one thing. I'm sure you know what the MD means. The FRCPC that I have is the same as the one that your neurologist has. Okay, it's a fellow of the Royal College of Physicians of Canada. All right, so I've got the same length of training. In fact, I spent 2 years studying the brain on the bench, your bench research, in addition in Calgary. And in Calgary, where I started training in 1983, it was the first place in Canada. At that time, they were just starting to do it. There was one cardiologist who was out in the forefront, Dr. Merle Knudsen and David Roth, also with them, and they were spending 4, 6, and 8 hours with people with coronary angioplasty. And all the people that did coronary artery bypass graft surgery said they were nuts. It would never be anything. But within a few short years, it became almost a standard of practice. And you can't talk to anybody in their 50s, 60s, 70s, or 80s that hasn't had chest pain and perhaps 1, 2, or 3 stents. Okay? So stents, and the angioplasty that you do in the coronary artery is a lot of ways parallel to what is talked about opening up veins. As you know, arteries take blood from the heart and then to the tissue. Veins, of course, are the reverse. They pick up blood at the tissue and take it back to the heart. That's important for a couple of reasons, all right? It's particularly important because it makes a difference to the flow pattern, and it makes a difference also to the issue of stents, all right? And that's why, it's talked about in that format. So let's just back up a little bit from there, but I wanted to make that statement out front because this is not as scary as some of us have suggested, to you that it is, perhaps. Multiple sclerosis, an autoimmune illness. This is not suggesting that any of that has changed. It has been known for 150 years that there was always a vein at the middle of the plaque in multiple sclerosis. Okay? So the veins have been somehow involved in this. And there's a number of times it's been suggested that that should be followed up and investigated. Several things have happened, and then, of course, Dr. Zamboni in Italy spent 25, 30 years studying veins. Now, veins, you learn in medical school, are very unimportant. Now, there could be an exception on that if you had nasty varicose veins, as both my parents had surgery for and my older sister. And so it makes me wonder, well, maybe my sister with MS and I also have a problem with our veins, but maybe not the lower half, maybe the upper half. So we don't know yet. All right? So if the veins are blocked, the concern is, of course, that there's some back pressure of blood to the brain, and therefore there is an extra buildup of pressure of blood and the deposition of red blood cells or iron. Most of you will know that if you get iron into the tissues of the body, it's quite irritating. If you get blood into a joint, you have major pain and inflammation happening to that joint. Well, the same suggestion is it may be the trigger, one of the triggers, to start that so-called cascade of inflammation and autoimmune disease. Okay? We are not saying that there is not an autoimmune component to MS when you're talking about CCSVI. It stands for chronic, more than 3 months. That's the definition usually in medicine. Cerebral, up here in the brain area. Spinal, because of course that's the other part afflicted with MS, both the brain and the spinal cord. Cerebral spinal venous insufficiency, meaning that there is not enough blood being drained away from the tissue. Okay? So it's a plumbing back pressure principle that is suggested. And of course, as most of you know, what I usually talk about is the journey with multiple sclerosis, because we all have a different, slightly, journey. We don't fit in the same box. 70% of us get headaches, 70% of us get muscle spasm, 70% of us get cognitive problems, 85% of us get fatigue problems, but I've met a few people that don't have fatigue problems, okay? So it's a different journey for each of us. It's also probably the solutions are a puzzle. And some of us will have pieces of the puzzle that work, that don't work for others. And I would suggest that look at CCSVI as a piece of the puzzle. It might be a very large part for you or for me, or it may not be. One of my friends recently was very disappointed. She was in Mexico and she did not have any blockage to her veins. Okay, so that piece of the puzzle isn't going to work for her. So that's sort of where the principle goes on. And there's several places, of course, studying that venous issue throughout Canada and the United States. It's being embarked on by UBC and University of Saskatchewan, and there's a bit happening down east as well. There's a lot more happening, I think, in New York State, in Buffalo and Albany. Stanford backed out of it, or the fellow had to. I think they will go back online, but Stanford case is worth bringing up because people may or may not have heard about it. There was a fellow in Stanford very keen to do it. It was in the early CTV report, one of the people that were done at Stanford, right? So the consequences of what happened at Stanford, the stent in one patient came out, okay? So it travels to the heart. In anesthesiology, we put a big tube into that internal jugular vein a lot of the time. We put it in whenever we do a heart bypass, and we put it in whenever we do an abdominal aortic aneurysm or in the intensive care unit, all right? Because the jugular vein, in many cases, is a straight pipe into the heart. And of course, the other thing that happens in veins, if you remember or think about it, they get bigger as they get closer to the heart. So that's the tricky part about the stent. It's almost brain dead to put a stent into a coronary artery because they get smaller and smaller and smaller. So what's the likelihood that the stent's going to disappear downstream where the blood flows? Almost none, because it's a smaller and smaller pipe. But it is more tricky to put it in the vein. And that's why, to this point, Dr. Zamboni, the fellow in Italy who originally described the whole concept, has suggested we should ideally wait until we have stents that will stay better or are more designed for the vein side, because they're getting bigger. Having said that, I'm sure we'll hear tonight there's probably someone on the panel up here with a stent in place. Because if I was sitting there on the operating room table, they've dilated maybe 2-3 times my jugular vein, say it's blocked, but it collapses as soon as they, take the balloon away, then I would be willing to consider a stent personally, okay? It's a decision that would need to be made at the time, so people need to think about it. So that's the issue about the stent. Now, the other thing that happened in the Stanford protocol, they had one of their people was treated, and their routine there was to put people on blood thinners in a major way for 6 months after. One unfortunate person happened to have a brain aneurysm burst. Now, unfortunately, when you have a brain aneurysm burst, this is when there's a young person on the football field or a young woman that's pregnant. We don't know when these will burst. Almost always when they burst, we have an unhappy outcome. But of course, they said, well, it's because she was on blood thinner. Well, your chances of getting to the hospital in the right time is even less, of course, if you're on a blood thinner. Most people do not survive those burst aneurysms anyway. But it was enough to have the neurology side of the people at Stanford shut down the program. Okay, so that's what happened. Otherwise, Stanford would be helping move this forward because there was a couple very keen there. Now, who is usually doing the procedure? Usually in Canada or in the United States, it's done not by a cardiologist. They tend to focus on vessels related to the heart primarily and somewhat the chest, all right? However, the ones to the brain and the neck are done by interventional radiologists. So these are radiologists with an extra year or 2 years of training, putting in small catheters up into the brain to open up a blocked area because maybe it's the carotid or another artery supplying and preventing a stroke from happening again. It's the same as preventing a heart attack, except it's in the brain tissues, and it's done by interventional radiologists, okay? So it's useful to know sort of the roadmap and the playing field, and then you can start to maybe understand the dynamics of interaction. So I think that pretty much takes us, I'm just going to refer you briefly to the diagram because you're going to hear some of these tonight. You'll see at the bottom of the diagram where there's that fork or Y, upside down Y, that's the external iliac. So that's the vessel as it goes through the groin. If you feel into your groin, you can feel that artery pulsing. Okay? Well, it is. All right, and right beside it, well, yeah, we're a mixed company. Maybe you won't do it here. But right beside the artery, it's very revolutionary. In medical school, they taught you they're always together. Nerve, artery, vein, and they are, pretty much. Okay? So the external iliac goes up, and now we're into the area called the so-called inferior vena cava, which is the big, big vein that drains the lower part of the body. And as you go up, then you get to the upper major vein, which is the superior vena cava, which branches off into the subclavian and then the jugulars. The internal jugular, left and right, typically right beside the carotid. You can feel your carotid pulse. That's the one you check in the gym to see your pulse. All right? You don't want to check them both at the same time because then you'll faint sometimes because the blood needs to get to the brain. But right beside is the internal jugular vein, and then there's usually an external jugular vein draining areas around the neck and head as well. But typically the brain is primarily drained by the internal jugular vein. Now, we all have variable arteries within us, but the arteries are much more consistent than the veins. Veins are extremely variable among us. Probably in the forming process, they took the path of least resistance. It's a bit like the roads on Vancouver Island. They built the logging road where it was easy to drive. It's the same when the veins are being formed when you're in utero and starting to have these veins created. It takes the path of least resistance, and the likelihood of having identical veins between any one of us is almost nil, all right? But there's